Hi everyone, I'm Dr. Clifford. I'm a medical oncologist and I practice in Pennsylvania. And today we're going to be going through an important topic, the case coming into you for the dreaded lump.
This show is brought to you by Brave Paws Anxiety and Stress Support Chewables for Dogs, thunderstorms, vet visits, fireworks, separation anxiety, and more. Every day can be a Brave Paws day. Check out mybravepaws.com.
We love our fur babies so much, but when they're stressed out, it makes us stressed out. Some dogs hate loud noises like thunderstorms and fireworks, and sometimes they just don't want to be left home alone. To help keep them calm in moments of stress, use Brave Paws Anxiety and Stress Support Chewables for Dogs. These plant-based chewables promote calm behavior with natural ingredients that have been clinically studied. Did I mention they're fast-acting and non-drowsy? I especially love that Brave Paws helps farmers in Costa Rica by sourcing ingredients from a woman-led co-op that uses reusable energy and regenerative agriculture. How cool is that? Learn more at mybravepaws.com.
Currently, I'm a medical oncologist, and these are the types of cases that I see all the time. All right, so let's talk about it. These are the types of cases that are probably coming to see you more than me. It's the dog that's coming in on your schedule for the dreaded lump. Generally, it's a happy, healthy dog. The owner may talk that the lump has been there for a several-month time period, may be slow growing in nature, and they want to come in to have it evaluated. So it's going to be important to talk to them about how long has the lump been there, and then also to take down the information as to the location, as to the size of it, go ahead and measure it, and then we'll talk about how best to then move forward in diagnosing what the lump represents. So when talking about the lump, although I am a medical oncologist, it doesn't necessarily mean that these are always going to be cancer. It's certainly possible that it could be a cyst, a sebaceous cyst, which we'll know about pretty quickly, or a simple fluid-filled cyst. It's possible that it could be an abscess, that there was trauma that led to an infection under the skin, or it could represent scar tissue from a previous traumatic site. But it is certainly possible that it may be cancerous. Still, that doesn't necessarily mean it's always going to be malignant. We know many of our tumors, such as lipomas, are very benign in nature, and they present as a lump as well. So what are the options at this point when this case comes in to see you? Certainly one of them is to potentially wait and monitor and take a conservative approach. As an oncologist, I certainly would recommend against that because we know for any type of cancer, the earlier we catch it, the better the prognosis will be. So without question, my recommendation for you is go ahead and do something. So be proactive with these cases. So in being proactive, though, clearly there's going to be a number of factors that are going to impact this. The first may be where it's located. Is it a difficult location to be able to try to aspirate or biopsy it? Will it require sedation in order to be able to do this? Or is it pretty obvious where the mass is that you can potentially aspirate to determine what it represents? So the next step is going to be how are we going to obtain the diagnosis? And that's usually where we kind of go between either cytology or are we going to biopsy it? Cytology certainly is the easiest, and that's generally what I tend to recommend. We know it's quick, it's easy to do, it's relatively inexpensive, meaning we don't necessarily have to have blood work because we're not going to be sedating them. It's something that can be done in practice very quickly. And for the most part, there's very minimal risk involved in doing it. You're not going to have excessive bleeding from certainly aspirating a lump. But there are some downsides to the cytology. Certainly, we could have a non-diagnostic sample. That happens if it's a small lump or there may be inflammation associated with it. We may not get enough of it to get our answer. And then also the other challenge is going to be, unlike with biopsy, we don't have architecture. So it may be challenging for them to be able to determine what it is based upon cytology. Having said that, though, my rule of thumb generally is start with cytology first to see if we can get our answer. It's quick, it's easy to do, and it's relatively inexpensive. So if we're going forward with aspiration, there's kind of two techniques that most clinicians will use. I tend to be more the one who will take the needle off of the hub and kind of use that almost like in a woodpecker technique to put it into the lump itself to be able to potentially determine what it is and then put that on the slide. The second one would be having your entire syringe pulling back on the plunger and then utilizing that to bring in more cells. Is one better than the other? I don't think so. I've always been the person that tends to use the hub of the needle while others tend to use the entire syringe. As long as you get your answer, that's perfect. The next step then is going to be applying it to the slide, laying the slide on top of it, and then pulling the two apart, making sure that you have a good monolayer there that we can then assess and can be looked at. All right, so we've done our aspirate. We have it on the slide. The next step now is to stain it. Most of us generally tend to use DiffQuick. It's the easiest one, and it's probably the most well-known of all of the stains that we tend to use. It's not perfect, though. Things to keep in mind are mast cell tumors may not always stain with it, so keep that in mind if you think you may have a mast cell tumor. Sometimes the granules will not stain with DiffQuick. Some have said it may be around 20% that we see this with. The other thing to keep in mind in regards to having the DiffQuick, if you do a fair bit of cytology, you should keep that away. So it should be away from the stains that are used for fecal, and it should be away from the stains that are used for dermatology, because the challenge you're going to end up with is you may see fungal hyphae in there, or you may see other things that may change what you think this is. So you should have a cytology set aside stain that someone is in charge of for changing it every couple of weeks to make sure, and replenishing it and making sure that it stays clean. The next step then, once you've done that, is assessing the slide. So we all don't have to be clinical pathologists to do this. The first thing that I generally tend to recommend is when you look under the microscope, is there adequate cellularity? Meaning, are you only seeing red blood cells, or does it look like fat? You're just seeing droplets of oil all throughout. That's clearly not a good sample, and you may have missed, or it just may be something you can't aspirate well. So when you first look, is there adequate cells, and are they intact? If the cells are all ruptured, when that gets sent off for cytology, clinical pathologist is not going to be able to give you an answer if the cells are not intact. So it's always good at least to take one slide and take a look. The next step is going to be the cells that you're seeing, do they represent what you're thinking the mass is? Meaning when you aspirate it, you're sure that this is a cancer, but you're seeing only neutrophils. Well, that doesn't quite fit. So did you miss it? Did you go through it? Are you only seeing red blood cells, but it's a solid mass? That would make me think we probably need to go back and aspirate it again. The second is going to be, is there a lot of inflammation? If we see a lot of inflammation, the challenge with that is if there is an abscess or a high degree of inflammatory process occurring, it can actually change the epithelial cells and mesenchymal cells, make them look uglier than they really are. So giving you the impression that it might be cancer when it's truly not. So these are the things to consider again. Do I have adequate cellularity? Do the cells I'm seeing make sense? And is there a lot of inflammation? And then with that, you can consider then potentially getting this ready to send it off. So we have our slide, and what I would suggest certainly is getting to the habit of having at least one slide you keep that you're going to look at, not to turn you into a clinical pathologist, but to get you more familiar with this and to make sure you're sending off good samples so you'll get back good results. So what we tend to then look at with the cells is, do we have the criteria of malignancy for them? So we look at anisocytosis and anisokaryosis, which is very simply is cell shape, cell size. Are they the same? Are they abnormal? When we look at the nucleus itself, the brain of the cell, are we seeing prominent or multiple nucleoli present within it? Do we see an increased nuclear to cytoplasm ratio? Does the nucleus look abnormal, or are they all identical? And then do we see any coarse or atypical chromatin patterns? These are generally what a clinical pathologist, when they look at cells under the microscope, use to be able to determine if it is malignant. So the other criteria that is often associated with malignancy is if we start to see a fair bit of mitotic figures, so mitoses that are occurring within the cell, which is very simply you're seeing the cell kind of breaking apart. It almost looks like someone took a shotgun to the cell. The other thing that we may see associated with malignancy are going to be multinucleated cells. Traditionally, we shouldn't see that in most normal cells, but it is something that's common for malignancy. So if you look down and you see a cell that has 4 or 5 nuclei present within it, that is often associated with malignancy. So if we feel we've diagnosed neoplasia, we tend to generally put it under 3 big categories. The first are going to be carcinomas, which are cancers of the epithelium. I tend to say cancers of the skin surface, lining of a body cavity, an organ or a gland. Sarcomas, which are mesenchymal cells, so these are generally cancers of deep tissue, or it may be a round cell tumor, which are generally our cancers of the immune system, and there are a plethora of round cell tumors. So again, if we're thinking it's a carcinoma, these are generally cancers of the skin surface, lining of a body cavity, an organ or a gland. And that's where the location is going to be important. If it's in the cervical area, is it thyroid? Is it salivary gland? We need to be able to look at that to determine what it may represent. If it's in the perineal region, is it anal sac or is it a perineal adenoma or carcinoma? The most common cutaneous carcinomas that we tend to see are squamous cell carcinoma, probably more common in cat than in dog. Basal cell carcinoma, more common in cat than dog. And then sebaceous adenomas or carcinomas, and these are definitely more common in dogs than anything. Most of the time, these cutaneous carcinomas only need local control. So the nice thing about this is that if we're able to diagnose them, we know that generally they're not cancers that have a high degree of metastasis. The vast majority only need surgery in the form of local control. So let's talk about round cell tumors, which is one of the other categories. This is a very broad category. Within it, we have lymphoma, which we know is rarely a solitary cancer. We tend to think of lymphoma as a liquid cancer. So for the most part, there is cutaneous lymphoma that can occur in dogs, but very rarely is that ever localized. The vast majority are more diffuse or systemic, thus they need systemic therapy in the form of chemotherapy. Mast cell tumor, which we're going to spend some time talking about today. Most of these are surgical. The vast majority of you listening in the audience, the surgeons out there, you're the ones who cure most of these. I only see the bad actors. So most of these only need local control. Plasma cell tumors or plasmacytomas. These often occur on the skin. They're red, oftentimes, sometimes irritated looking, but they are very easy to remove. If they are, again, all you need is local control. Surgery is curative to them. Histiocytomas, which is another round cell tumor. These are cancers of histiocytes, and we call these the great surgical emergency. They're going to kind of pick out to you based upon the history. It's usually going to be a young dog. They often look button-like, and the reason we call them a surgical emergency is they're one of the only cancers that our immune system actually goes and removes. It takes it away. So if you aspirate one and you see lots of lymphocytes that are present in the sample, that means the immune system is already gearing up to remove it. Hence why we call it a surgical emergency, because if you don't go and remove it, it's going to go away on its own. The more malignant version of this would be histiocytic sarcoma, a cancer that often occurs in Bernese mountain dogs, golden retrievers, Rottweilers, etc. This is a much more aggressive cancer, generally requires surgery for local control, but then also chemotherapy for systemic control. Transmissible venereal tumor, that's very much geography based. Most of the cases that we tend to see are dogs that have been adopted from other countries, and they come in with this. We know it's a sexually transmitted cancer. This is also one that can be removed surgically, or it can actually be curative with injections of vincristine. And then finally, we sometimes throw melanoma into the round cell tumor category. And melanoma is quite interesting because sometimes it can look epithelial, sometimes it can look mesenchymal, but it can also look like a round cell. So it's one of the odd cancers that can kind of flow between all 3 groups. For the most part, if melanoma is occurring on the outside of the skin, cutaneous melanoma, they're usually less aggressive in nature and cured with surgery. 2 locations tend to be more aggressive in nature, the digits and the mouth. These need not only local control, but systemic control. And the vast majority of oncologists usually use the melanoma vaccine for this. The final group are sarcomas. And the way I try to tend to break them down is we have 2 groups, typical and atypical. Typical are the vast majority of the ones you deal with on an almost daily basis of the dog presenting with the lump. The typicals are usually less aggressive in nature. They're slow growing. The way we always talk to owners is we kind of view them as an octopus. The lump that the owner feels is the head of the octopus, and many of these have tentacles. And that's one of the challenges because they love to occur along the extremities, which makes it difficult for the surgeon to be able to remove them completely. But the good news for the typicals is the vast majority are less aggressive in nature. They only need local control. We tend to then give them a grade, and they're either low grade, less aggressive, moderate grade in the middle, or high grade. The vast majority of the typicals are lower moderate grade, and we've learned through those that all you need is local control. There's also some interesting data that suggests even if you may not have very good margins or incompletely excised, some of the true low grade ones may not grow back even though they're incompletely excised. Right now with the typicals, we put them under an umbrella term called a soft tissue sarcoma. Back 10 years ago, we used to say it was a fibrosarcoma or a peripheral nerve sheath tumor or a hemangiopericytoma. What we have found is biologically they all behave about the same, especially if they're lower moderate grade. So for the most part, the exact cell of origin or tissue type doesn't matter. We use an umbrella term called soft tissue sarcoma, and that's what you'll see in most of your path reports. If it is low or moderate grade, all we need is local control. If it's high grade, the risk of metastasis is much higher. It's close to 50%. So many oncologists will follow those patients with systemic therapy in the form of chemotherapy. Again, having said that, the vast majority are lower moderate grade, and they're cured by the viewers listening to this. The second group are called the atypicals, and these are definitely the bad actors. The atypicals get their own name: hemangiosarcoma, osteosarcoma, among others. These are the ones that are locally aggressive, certainly, and we need to remove them, but they also are aggressive systemically. They have a much higher metastatic rate, and we need to do full staging on these patients before we remove it, because if they're in the small percentage that have metastasis already at diagnosis, well, then we're doing them a disservice by removing the primary tumor if it has already spread. So the atypicals we have to do a little more to. Those are going to be the ones that we may ultrasound, certainly chest radiographs on all of them. And when they're removed, we need more than just local control because generally the overall survival is only a few months. Those patients without question need systemic therapy. And traditionally in our hands, we tend to say when we add systemic therapy after surgery, we can usually at least double to triple the survival versus surgery alone. All right, so in summary, the things that I would recommend when these cases come in, I would be proactive. I would not sit on them. As an oncologist, I've seen enough of the cases that were sat on for a prolonged period of time and then the dog ended up developing metastasis or was no longer surgically resectable. So be proactive. I would also recommend getting into the habit of aspirating, looking at the slides yourself. That way you can start to have a better understanding of them and then compare against what the clinical pathologist finally comes back with. Have your team get into the habit again of taking your stains, having a stain that is set aside only for cytology. And one person is involved who does all of the dipping of it so they understand exactly how to do it. That way the whole group is involved. Always when you have lumps come in, measure them and put down the measurements. Because for me as a medical oncologist, many of the cancers, the prognosis depends upon the size of the tumor. So the measurements are infinitely important. Again, the final thing is going to be most of these are cured with surgery alone, so be proactive. So that's what you need to know in order to work up the dreaded diagnostic approach to the lump. If you like this program, please hit the like button and stay up to date on everything vet med by subscribing to this channel. If you'd like to hear more from me, you can follow me on LinkedIn or on Instagram. Thanks so much for watching, everyone.